Hello and welcome to our last installment of our Chapter 9 lecture on articulations. This video is going to cover the structure of the shoulder, the knee, and I'll talk a little bit about 3 types of arthritis at the end. So the shoulder, all right, so we're going to start here with the shoulder joint, also called the glenohumeral joint, because it is the joint between the glenoid cavity or glenoid fossa of the scapula and the humerus. So glenohumeral joint. Shoulder joint is fine. And it's pretty complex. So you can just kind of see by looking at these diagrams, there's a lot of stuff going on. But do know that we are looking at an anterior view like this. And we're also looking at a lateral view with the humerus removed, just looking at the scapula straight on, like this view versus this view. Right? So this is the lateral view, and this would be the anterior view. Okay, so all of the lists of the ligaments, the muscles, and the bursa are all listed here in the notes, so you can be following along with that. So I'm going to start by taking a look at the ligaments. I have my clavicle. So the clavicle sits somewhat like this. So the clavicle articulates with the acromion process right here. Okay. So our first 2 ligaments I'm going to take a look at are called the coracoclaviculars. Okay. So remember, this is the coracoid process on the clavicle, on the scapula right here. So when we have the clavicle right here, there's going to be 2 ligaments spanning from the clavicle to the choroid process, kind of like this. Okay. So those are those guys there, coracoclavicular. Then we have coracoacromial. So the coracoacromial, so here's your acromion process. Here's your coracoid process. So this is just going to be a ligament spanning just between those 2 parts of the same bone. They're not even spanning over a joint, just more stability. And then the last one, or the other one we have here is the acromial clavicular. So where the acromion and the clavicle meet, there's going to be a ligament connecting those together. This is actually its own joint that's discussed within the larger whole of the shoulder joint. So this is called your acromioclavicular joint. You might also have heard it be called the ACL. There's also an ACL in the knee, so we don't want to get those confused. So acromioclavicular, if you've ever heard of somebody having a separated shoulder, this is where that damage happens. So if they damage right in here, that's a separated shoulder between the clavicle and the acromion process on the scapula. Okay, so then we have, so acromioclavicular, coracoacromial, coracoclavicular, and then we have deep in here that we can kind of see, we have coracohumeral and glenohumeral. So these ones are a little bit harder to see. You will be able to see some of these in the models in lab. So coracohumeral, just as the name implies, it's going to go from the coracoid process to the humerus. So again, it's going to be more of the base of the coracoid process going over and connecting to the humerus here. I don't know if you can see that very well. From the coracoid process to the humerus. And then we have the glenohumeral ligaments, which are kind of originating deep inside the joint at the glenoid cavity. And there's like 3 of them that kind of wrap around the head of the humerus. And you can see those like 1, 2, 3. So looking at it this way, we can't see them because they've been cut because the humerus has been removed. Okay? So we have 3 coracos. So we have 3 ligaments that come off the coracoid process. Coracoid to clavicle, coracoid to acromion, and coracoid to humerus. Then we have the acromioclavicular and the glenohumeral. So those are all the ligaments associated with holding the bones together, holding the humerus into its socket. The other thing are the muscles, and the muscles are actually the major stabilizer in your joints. And muscles aren't that strong of stabilizers. I mean, they're strong, but they're soft, squishy tissue. So we have the supraspinatus, and we'll be learning about this in your muscle list. So supraspinatus, infraspinatus, teres minor, and subscapularis. Now, you just need to know for this chapter that those are the names of the muscles of what we call the rotator cuff. So if you've ever heard of anybody with an injury in their rotator cuff, it's one of those muscles that have been damaged. You don't need to know where they are on the picture or their origins or insertions or what they do. That's all going to come later when we get into chapter 10 and 11 with our muscle list and stuff. But right now you can at least remember the names. Again, they're listed here in the notes of the 4 muscles that make up the rotator cuff. And then lastly, the other structures that we can see associated with the shoulder joint are the bursa. And again, their names are going to tell you where they're found. So we have the subcoracoid, we have the subscapular, we have the subacromial, and I think there's a subdeltoid. So there's 4 bursa. Sub just means underneath, and then whatever they're underneath. So subcoracoid is going to be underneath the coracoid process. Subacromial is going to be under the acromial process. Subscapular is going to be under the subscapularis muscle. And then the subdeltoid is going to be under the deltoid muscle, which is this big shoulder muscle here. So if somebody's doing repeated activities like a pitcher or something like that, or playing tennis, you're going to increase the inflammation and the movement on those bursa. So you might get bursitis of an inflamed bursa, maybe under your subscapularis muscle or under your deltoid muscle. So those could be some issues that you have if you do repetitive movement activities. All right, so that is our shoulder joint. The next, I have pictures. So I wanted to show you the x-ray of the shoulder joints just to show you if you didn't have the ligaments and if you didn't have the muscles, that humerus would just fall right on out of that glenoid fossa because there's no bony connection holding it in. It is all the muscles of the rotator cuff that support and hold that bone in. Yes, there's a few humeral ligaments like the glenohumeral and the coracohumeral, but they're not super duper strong. It's those muscles of the rotator cuff that really stabilize your shoulder joint. But because the muscles are flexible, our shoulder joints are flexible. Okay. All right, now we can move on to the knee. So the knee is also a complex joint because it is between 3 bones. We have the femur, the tibia, and the patella. So I have my femur, I have my tibia right here. I'm not going to dig around for the patella. It's at the very bottom of my bone bag. But, so this is our knee joint. This is the anterior surface. The patella would sit right here in that surface. And here's the posterior surface, kind of the posterior view of my knee joint. So we have 2 articular surfaces between the condyles of the femur and the tibia, and then we have the patellar surface for that articulation there. So again, we have the names of the ligaments and things that we need to learn right here in that section of the notes for the knee. So we have a capsule because it's a synovial joint, but it is an incomplete capsule. So it is not fully formed in the front of the knee, but what we do have are all of these ligaments, and the fat pad kind of helps seal in the synovial fluid on the anterior surface. We do have a joint capsule on the posterior surface. You can kind of see it there on that picture. So ligaments, okay, let's take a look. There's lots. So on the anterior surface of the knee, we have 2 what are called patellar retinacula. So these go on either side. Again, I don't have my patella. I wouldn't be able to hold it up anyways because I don't have that many hands and fingers. So on either side of the patella, you're going to get these retinacular ligaments kind of going from the femur or from the patella down to the tibia down here. Then we have our medial and lateral sometimes they're called medial and lateral collateral ligaments. Your book's calling them tibial and fibular collateral ligaments. So again, here we go. So on our tibial side, you're going to have a ligament that's going from the femur to the tibia. And then on our fibular side, I can only hold so many bones at once. So our fibula sits like this, and the femur is going to come up and sit here. So then we're going to have a ligament that's going to go from the femur down to the fibula. And if I had another hand, I would show you, but it's going to go from like here up to here. Okay. So we have a tibial collateral ligament and a fibular collateral ligament. Okay. And then on the back side, we have a few popliteal ligaments that kind of help to reinforce the joint capsule on the posterior side of the joint. So those are all of our extra capsular ligaments. They're outside of the joint capsule, helping to reinforce. Inside, we have our two cruciate ligaments. Cruciate means cross. So you can see we have our anterior cruciate ligament kind of starting on the front of the tibia and going back. So there's the other half of it, attachment point there. And then we have our posterior cruciate ligament that starts on the back of the tibia here, and then that's going to be its attachment point there. So they cross in between. So that's the other ACL. So remember, if I mentioned in the shoulder, we have the acromioclavicular joint, ACL joint. This is called the anterior cruciate ligament. So a lot of times, if it's an injury that you hear of a lot in football players, ACLs and PCLs, that's your posterior and anterior cruciate ligaments, or your MCL or your TCL, which are your tibial or medial collateral ligaments. So if you have knee injuries, those could be some of the tissues that could be damaged, those ligaments that help to support the knee. The other thing that we see are what are called menisci. These are like crescent-shaped wedges of fibrocartilage that sit, right? So here's the condylar surfaces of the tibia. And so in these kind of crescent shapes here, and you'll see this in the joint model in lab, this is where your menisci sit. So medial and lateral. So if we're looking at our tibia, here's your medial malleolus. So we'd follow that up. So this would be the medial condyle with the medial meniscus, lateral condyle with the lateral meniscus. So that helps to stabilize these condylar surfaces. So they're not going to go lateral like this because they're going to be seated in those nice cupped menisci made of fibrocartilage, which helps to resist compression every time you take a step. All right, so that's the structure of the knee. So lots of ligaments, and then they just name bursa. They don't name them, they just call them bursa, but you're going to have some bursa like we saw in the bursitis diagram. There's going to be anterior bursa that would be right here on the patella, and then we can see some in between some of those muscles and the ligaments on the posterior side of the knee. Okay, all right, so that wraps up all of our representations, all of our joints. The last slide here, I'm just going to talk about the three types of arthritis that your book mentions. So the first type is called osteoarthritis. So this is your typical wear and tear, usually associated with age. A lot of times you see like the Aleve commercials or the Motrin or whatever, pain reliever older people are going to take for their arthritis pain. This is osteoarthritis. You usually do not see that show up in younger individuals because their cartilage is still nice and smooth and strong. But once it wears away over time, it doesn't replace itself. So your cartilage, avascular, it doesn't repair. So if you get kind of all this trauma, it's going to be painful, and that might lead to a knee replacement or a hip replacement or something like that. The next one that we have in the middle here is called rheumatoid arthritis. This is an arthritis that is triggered by an autoimmune reaction. So your immune system has antibodies, which go and target foreign things, and that's the job of the immune system. In rheumatoid arthritis, for whatever reason, some of your cells are making antibodies that target structures of the synovial joint. So in here we have all these heat-seeking missile proteins, and instead of targeting and destroying bacteria or viruses, they're targeting and destroying the tissues of your synovial joints. So like the synovial membrane, the articular cartilage, those types of things. And it can be very painful and very deforming. So, and there's really not a lot of treatment other than immune suppression because it's the immune problem. It's an immune problem. It's an autoimmune problem. So you'd have to take medicine that quiets down your immune system, but the side effects of those are you're at more risk for other infections. The last type of arthritis is gouty. So we had gouty, rheumatoid, and osteo. So gouty arthritis is an interesting one. It a lot of times comes from diet. So depending on the food that you're eating, the way your body metabolizes certain proteins and foods, is they produce uric acid. And these uric acid crystals tend to build up in the joint between your first metatarsal and your proximal phalange number 1 of your toe, your great toe joint, if you will. And these uric acid crystals build up in the synovial fluid in the synovial cavity. And, imagine trying to move a joint when you have all these sharp crystals in there. So it causes swelling and inflammation, and it's very painful. So gouty arthritis, very similar disease processes. Okay, that finishes it up. So that is the last bit of our chapter 9 material. So this is the end of the material before our second exam. So exam 2 covers chapters 6 and 9, primarily going to be on the lecture exam. 7 and 8, if you remember, were all the bone list things. You need to know your bone list inside out, upside down. Hopefully you're memorizing that and be ready to answer questions about the bone list on the lab practicum and a few questions on the lecture exam, but primarily 6 and 9 will be the material on exam 2. All right, I will see you later. Bye.